Good afternoon. At the outset, I'd like to thank Professor Abdul Adud Chaudhary, our teacher, mentor, Dr. Mohsin, for inviting me in this forum, giving me this opportunity to talk something. As all of us, we know that AVM is the last chapter in neurosurgery that Shomon told. So treatment of AVM depends on how we know the anatomy, how we analyze the AVM. That means we have to check the CT, CTA, MR, MRA, DSA, and we have to be very sure about the topography, relation of AVM with surrounding brain, its feeder, draining vein, and nidal analysis. Overall, we have to be sure about the 3D understanding of the AVM. So how we treat? Endovascular, microsurgery, radiosurgery, or no knife, do nothing. So it can be individual or it can be combined. There are few of the diseases. For those diseases, surgery cannot be applicable. Surgery is absolutely contraindicated. This is a kind of schematic diagram made by one of my residents. Does it play? That's how onyx walks into the AVM and feels the nidus. And that's how onyx goes into the AVM and it's feeling the nidus slowly, slowly, slowly. One thing we have to be sure that until it goes up to the footplate of the vein, this AVM embolization is incomplete. Transarterial injection may shows that we have achieved complete occlusion, but eventually it may recur because of remaining of the footplate, and that will invite the feeders. This is our experience so far. The left hand side is for spinal vascular malformation, and right hand side is for brain vascular malformation. So far, we embolized 111 cases in case of brain and 65 cases in case of spine. And our experience we divided into two parts, last 3 years and before that. Our experience in last 3 years is quite good. Our complication is significantly reduced and our embolization cure rate is also increased. That's how we fragment, how we treat. If it is close to surface and small, we take it by surgery or embolization. And if it is deep or eloquent, we prefer embolization first, followed by radiosurgery. Surgery comes last. And if it is unruptured, radiosurgery or embolization. And if it is large, it is unruptured, then we would like to observe the patient. Or if it is ruptured, then we can individualize every case based on the size and location. We can stage embolize. We can do surgery following embolization to reduce the size. That is hybrid. And in case of spine for dural fistula, we prefer surgery first, followed by embolization. We do both, but we prefer surgery first because it is easy. And for perimedullary fistula or pial fistula, we prefer embolization. And if we fail in some cases that we have experience in failing 2-3 cases, we do surgery. Paraspinal stage embolization. So there is a question, does hemorrhage reduce is risk for surgery? Actually, no, because in AVM surgery, the plane is important. This is the plane that is on the surface, and the rest of the plane we have to dissect out. If there is a hemorrhage in one side, it rather creates a surface. That's true for this patient. It makes the surgery easier. This is the blood, this is the nidus. This is plane created by nature, so the excision of the nidus would be very easy. These are the surface AVM. We excise the lesion by surgery, and this one is small lesion in case of 12-year-old boy. We excise the lesion because we have to remove the hematoma as well, and patient improves significantly. There is a small AVM in the frontal opercular region. There is no defeated nidus for this patient. All nidus are in passes. So patient prefer embolization, but embolization is not possible for this patient. If we prefer embolization, then transvenous should be the only option, and that is costly. So we prefer this patient for surgery, and we completely excise the lesion by surgery. This one is 23-year-old girl, computer science student of university. She had left-sided Sylvian stroke. In this patient also, we embolized, we reduced the size, and followed by evacuation of the hematoma, and the leftover small part was taken by radio surgery. We analyzed every case based on its safety and efficacy. So we choose for this patient, embolization followed by evacuation and radio surgery was the best treatment for this patient. This one is also deep perforator was the feeder, 19-year-old boy, presented to us with deep left-sided bleed. So we also embolized this patient. Small leftover part was there after embolization. And after embolization, we took the blood. Patient is improving significantly. The leftover part will be kept under follow-up. It can be taken by re-embolization or it can be taken by radiosurgery as well. And this is a small boy. We treated this patient 2 years back. He came to us after second bleed. We embolized. And there was a small leftover part because ventricular striate artery was the feeder, perforator was the feeder. Then the patient was referred for gamma knife and patient is cured. This is post-gamma knife image. And this is a difficult issue. This patient presented to us with subarachnoid hemorrhage. And you see aneurysm here and AVM here. And if you want to treat this aneurysm endovascularly, this is again difficult. And if you want to take this aneurysm along with this nidus, it is too costly as well. In Bangladesh, you have to consider the cost all the time. So we excise the lesion. In single sitting, it is done completely. AVM needs bypass also. It's a funny story, but it's true. This was treated in some other hospital, evacuation of blood along with part of the nidus. On angiogram, we show that small nidus was remaining, but there is oligovascularity in this territory. And patient presented to us with some cortical features. So we did bypass for this patient and patient improved significantly. He was a university student. Very small AVM with nidal aneurysm. It is easy to take by embolization. You see, this is also very small aneurysm, small feeder. We took by embolization in a single sitting. The same case, serving army, and we completely embolized in a single session. Gaining of confidence of the patient is important. It takes time and it sheds blood also. We saw this patient 2 years back. Patient refused intervention. Patient went back. She came to us after 2 years following rebleed, and we completely embolized this patient. So I have to hurry, no? So hybrid means we take the patient by embolization first, followed by surgery. This patient we embolized the day before, and we excised the lesion the following day. We used to do it before, but once after partial embolization, we found a bleed at that night, and we have to rush the patient for emergency surgery. After that, we changed the technique, same day technique. For this patient, we embolized the deeper feeders, and we took the patient same day for surgery, and we excised the lesion. And this white mark is the remaining of embolizing material. So I have to pass forward. And this one is a pregnant lady presented to us with bleed. We just embolized the nidal aneurysm only. This patient is under follow-up for last 7 years and she's doing good. This is dural sinus malformation, huge venous leg. We embolized this malformation in 2 stages and completely embolized, and patient is doing very good. This is a vein of Galen malformations. We are doing it regularly. As of now, we treated 6 cases of vein of Galen malformations. So let's escape it. Okay. So malformation is there in vascular abnormality is there in spine also. This young boy presented with spinal cord bleed with quadriplegia and respiratory difficulties. So we embolized followed by surgery, and this is paraspinal. Yeah. So thank you very much.